Welcome to today's webinar. PYA understands the importance of clear, relevant, timely information to the industries we serve. So we offer a variety of webinars, white papers, articles, checklists, and other tools, all for free. Subscribe to our e-newsletters, follow us on social media, and subscribe to our PYA Webinar Recast podcast series for audio-only versions of all of our webinars at pyapc.com. If available, presentation materials used in today's webinar can be downloaded from the handouts panel. You will also receive an email after the webinar with links to any available slides. All of our webinars are available on demand at pyapc.com. Please stay on the line after the webinar to complete a brief survey and post any questions you may have. Thank you for joining us. Here are today's presenters.
Okay, looks like we are all settled, so let's get this party started. Welcome everybody to an episode of PYA Unscripted. Today's version is the first in what we plan to be a series of short but content-rich webinars focused on ambulatory care and the important role it plays in lowering the overall cost of care in the United States. Our webinar series is called Ambulatory in Action, and the concept is free-flowing dialogue and information exchange between high-level healthcare leaders working to put patients first by improving quality and lowering costs. Knowing our audience is busy executives, we will work to keep all of these sessions to no more than 45 minutes, ideally 30 minutes or less. We're very pleased you've joined us. My name is Deuce Lukemeyer, and I have spent the last several years as a principal with PYA. Prior to that, I spent just shy of 30 years in an academic medical center where I sat in more seats than we have time to mention. But it was everything from practice manager to the C-suite, and I had primary responsibilities ranging from contracting to finance to operations and strategy. I would be remiss if I didn't start by saying my career has benefited exponentially from incredible colleagues with track records of success in putting patients first. I'm going to ask our panel to introduce themselves, but valuing the patient is truly the mantra for this panel of subject matter experts, and they represent three of the brightest minds I've had the pleasure to work with and learn from. Dan Handel and Jim Laughlin bring the added clinical perspective as top performing physician leaders. Scott Black brings the vision of the CFO tasked with leading strategy and operations in ambulatory environments. So I'm going to let them introduce themselves. Scott, we're going to start with you. Please introduce yourself, and then we'll just go alphabetically, and you can throw it to Dan and then to Jim.
Thanks, Deuce. As Deuce indicated, my name is Scott Black. I serve as the CFO of a business unit of IU Health called System Health Solutions. And while that doesn't mean much, what it really represents is our division to advance value-based care. It has a number of clinical ambulatory settings, as well as our health plan, and actually our community health is part of it as well. I've been at IU Health for about 26 years, and prior to that, I served in a public accounting firm for about 15 years. Dan?
Thanks, Scott. My name is Dan Handel. I am a board-certified practicing emergency physician by background. I started my career in research, health services research, and informatics, and eventually got into operations. I've served in several different chief medical officer positions over the past decade, and I'm currently the CMO for the central area of Atrium Health, which includes Carolinas Medical Center and Mercy Hospital, based in Charlotte, North Carolina, which is part of a 67 hospital system known as Advocate Health. So thank you very much. I'm glad to be here. Go ahead, Jim.
Thanks, Dan. My name is Jim Laughlin. I'm a pediatrician. Started out in solo practice in 1981 in Bloomington, Indiana. And in the mid-90s, realized we needed to form a group in order to survive with the advent of managed care and electronic medical records. So formed an independent pediatric physician group, which rapidly grew to serve approximately a 10-county area. In 2012, our group merged and became one of the founding groups to take on the role of multi-specialty group of South Central Indiana as part of IU Health. And subsequent to that have been the pediatric group leader and also a dyad structure leader for our physician group for the region. Just recently retired, but still doing some work.
Thanks, Jim. So you can see that clearly this panel has many years of extraordinary experience. I thought it might be informative if we could start by asking each of you to describe what you see as the significant events within your own career experiences. And they could be from either an administrator or clinician perspective, the things that you have seen that have shaped ambulatory care and brought it to where it is today. Scott, let's keep that alphabetical thing going, and let's start with you.
Thanks, Deuce. Yeah, as I look back on my career and think about some major changes, when I first started with IU Health, one of my first responsibilities was to convert a number of office-based clinics to hospital outpatient departments. And the sole purpose was to maximize our revenue at that time. And we did that for a number of years, actually converted a number of practices, and really got good at trying to design and develop HOPDs to maximize our revenue. Over the years then, our thinking began to evolve, and through a number of reasons. One was patients were getting wise to this, and rightfully so, understanding what it means to go to a physician office versus an HOPD and getting a split bill. We also started to see some steerage from insurance companies away from HOPDs into physician offices. We also just began to think, if we're really trying to lower the cost of care, is this really the right thing to do? So the past several years, we have gone away from HOPDs and really are on a path then to eliminate it altogether, that it won't matter what side of service a patient might go to, it will be the same charge. And I think it's come a long way and has almost done a 180 in terms of where we started to where we're going. But I truly believe it's the right thing to do to really help with overall care affordability.
Well said. Dan, how about you? Your emergency medicine background and your research start to that probably gave you kind of a unique seat in how this was evolving. I'm really curious to see what you've seen and where you see things today.
Yeah, no, I moved from doing health services research, really looking at how impediments to patient flow in the inpatient setting compromise the outcomes of patients, to trying to kind of flip to the other side on the hospital side and trying to do something about it. So, as I said, I served in several different types of CMO roles, both in academic centers, quaternary centers, more regional centers with community hospitals and critical access hospitals. And it's really, there is an ongoing shift of independent physician practices, whether the practices get bought up by hospital systems or payers or even private equity. How do we make that transition that at the same time creates mutually beneficial financial models, both for the hospital systems and for the ambulatory practices, but also more importantly, optimizes access to care for patients? And we've been living and dancing in this balance between volume-based care in terms of more patients you take care of, the more revenue you bring in, versus value-based care. And how do ambulatory practices dabble in both and be able to create that muscle memory to flex up as much as they can, as much as payers will allow them into a value-based world. And then obviously, different specialties will approach that differently. If you're in a more generalist or primary care setting like Jim is, prevention, trying to maintain health and looking at a holistic, versus when referrals are made to specialists, how do you kind of do that crosswalk where we're really aligning incentives? So it's really trying to be intentional on this journey of how do we at the same time support ambulatory practices, to provide care in the most outcome effective, cost effective way, but at the same time creating those complete continuums of care. So the days of having isolated ambulatory practice where they have patients, their electronic health record does not communicate with the inpatient world or the post-acute care world. How do we create that seamless transitions of care? You know, whether any of us personally have experienced or if we've had loved ones or family members, we all see the fragmentation, and we really need to continue to work to make sure that care is better coordinated so that there's clear transitions, things do not get lost in translation, there's not duplication of care, and more importantly, there's not omission of care. So it's a continuum. I really look at us still very early on in that journey. And when we look at other countries around the world, some do it much better than us. There's some countries that, you know, they're where we were in the 80s or 90s. So, you know, we're not the best at this, but we're probably globally not the worst at this either.
Well said, too. So, Jim, you probably have had the seat that's been at the closest to this transition. And I think one of the things that has always impressed me about your background and how you set things up is you understand how to make an office run. You understand productivity, you understand access, you understand those elements that go into the continuum that Dan just described. So from your seat, tell us what you've seen and what are the significant events that have occurred that have shaped your office-based care to what it is today.
Well, there are a variety of events and trends. So sometimes it's not just one event, but it's the trend of what's coming up and the challenges that we face and how do we adapt to that, which has always been the fun part of medicine and leadership for me. One of the things that probably was a bold move on our part, I thought at the time, was when we formed our pediatric group. We started with 5 pediatricians, and then we grew that model. But one of the things that we decided from the outset is access and availability and quality were going to be our mantras. And so we set up a practice where we were open 365 days a week, including holidays. And by being able to do that, it was a challenge for us. But as we grew, we were able to fill the slots with the providers and the staff that we needed to do what we needed to do. But we were also able to show ourselves in our patients and the hospital that we could take care of a lot more kids in the right setting at the right time for less money. The funny story I remember when we first started our after hours care on the weekends and evenings, I got a call from the hospital CEO and asked to meet with me, and she was upset because that first month of opening our after hours clinic, we saw over 400 patients in our after hours clinic, and she was really mad because that was hurting her business. But that was the right thing to do, and I've stuck with that ever since. So that's probably a fun defining moment. But I think, as Dan alluded to, one of the challenges that has been also more fun as time's gone by is how do we integrate with the bigger system? How do we utilize those resources, and how do we do things so that we're seeing patients, continue to see patients at the right spot? Because that's where you're going to save the money, and that's where you're going to provide, I would argue, better care, having that patient seen by the person and the provider in the group that they should be seeing. So those are the most telling things in my mind.
That is thought-provoking, because what you just talked about made me think, and I'm going to throw a question kind of back at you, but what you talked about was a lower cost of care setting in a physician office that was capable of seeing a higher acuity patient than perhaps most of the clients that come to PYA are accustomed to. So from your perspective, what's the secret sauce? What did you do that let you keep those people out of the emergency room?
Well, we had the philosophy, and still do, that if somebody calls in and to be seen, even if there doesn't seem to be an open spot, we find an open spot to see him that day. And so we will see the kid who has respiratory distress from an asthma attack, or the mom is worried because they're not acting quite right, or they have something simple like a sore throat and a fever. We would much rather see them in our setting because we know we can see them efficiently for less money, more convenience, and probably have a better outcome.
Interesting. Very good.
So Jim, if you don't mind, so you touch on something really important. It's really owning your patient population. And, unfortunately, I think the national trend we're seeing is more and more ambulatory practices very focused on very discrete hours. And, as an ER doc, nothing pains me more personally when you call a service after hours and they say, if you have any other emergent issues, go to your local ER, and there's no discernment of, is this a true emergency? Is this something where with the appropriate after hours support, we can talk you through it and we can get you in next morning? Or, there's kind of a knee jerk. And, unfortunately, the future of American healthcare is not building more and more inpatient facilities, right? Whether you're in a CON state or a non-CON state, and I've been in both, either it's the approval process of being in a CON state, or even if you're not in a CON state, just the lag time and high expense of building more inpatient beds. Okay. If we have any hope of getting to a much more cost-effective healthcare model in this country, it's not building more hospitals. It's really empowering our ambulatory spaces to own patients, to take care of patients, and then when appropriate, escalate it to a higher level of care versus the default is go to the local ER, they'll figure it out for you. Because that, patients don't like it. I don't take it personally. It's, where I work clinically is a chaotic space. We don't know you, we don't have that longitudinal relationship with you, and it's like starting all over again. So I think particularly as you're seeing more consumerism enter healthcare, which I think is a good thing because it really empowers people to make a choice, they're going to go where they feel they can get care where they want it, not where kind of the knee-jerk and historical preferences have been just to send them to wherever the easiest thing to do at 2 a.m. So those who create primary care models, just-in-time models that operate 24/7 at point of care, those are the ones who are really going to thrive in this system moving forward.
Yes, what I'm seeing is a bunch of puzzle pieces that need to fit together. And Scott, you talked about your role as trying to influence more and more value-based care settings. So I'm curious, that my brain immediately went to, what are the barriers that you see? What is it that's barring utilization of lower cost of care environments? What do you see that's making it difficult for value-based agreements to maybe not proliferate, but be more common?
Yeah, it's a great question, Deuce. As I think about this, probably three things, and Dan did a great job of hitting on the first one. There's just this muscle memory of how things work, and it's just, you go to the ED if you have a problem. And again, some people realize they're probably not going to have to even pay when they go to the ED, just in where they have to if they go to an office. So I think we've got to change that. I think that is a major issue. We also don't provide good enough information on what's the appropriate care setting. As consumerism happens in healthcare, as Dan alluded to, I don't even know sometimes, I remember when my daughter was very young and she had some real breathing problems, and I took her to the ED, and then our health plan denied it at that time, saying it wasn't a medical emergency. And I'm a new parent, I don't know what a medical emergency is. And so we need to do a better job of educating the consumer on what the appropriate setting is and what the price is. I've seen some great charts that combine the clinical capabilities of the setting with the price of the setting, just in terms of dollar signs. And I think the more we can do that. And then I think one of the bigger impediments to value-based care, and it's tying what Dan and Jim were saying, is as we enter into these risk-based agreements with payers, what we find is our ability to manage the total cost of care is dependent upon patients being attributed to our primary care doctors. And what has been happening is, as we enter into these agreements, they're just looking for homes. The insurance companies are looking for homes to put people. And so we're being attributed to patients we've never seen, or maybe they saw one of our cancer specialists years ago. And it really frustrates our doctors because, you know, they're being held accountable to perform under these contracts, and they don't even know who 25% of the patients are. So we've got to do a better job of working with insurance companies that really tries to identify those patients that we can truly impact, not only the care that's provided, but the cost of care as well.
Good, good. Jim, from your perspective, as you hear some of this conversation, what do you think are the things from a purely office leader? How do you empower your team, and what do you tell your newly hired providers is the expectation for them today?
That's a really good question, because I was thinking as Dan and Scott just talked, I think one of the keys to our success, and one of the keys to provider satisfaction and incentive going forward is they've got to feel that they're being supported, and they also have to have a feeling that what they're doing is meaningful, which means that I think we need to incentivize our providers, particularly our physicians, to be the leaders of their team that's taking care of these patients. We also need to provide for them the support system so that they can do their job at their highest level. You know, we talk about performing at your highest level of care, and most physicians are not doing that in primary care because they've got so much other busy work to do. We've always had a high percentage of our staff being RNs, which is completely contrary to most models of staffing. But I tell you, that's allowed us to be twice as productive and give the patients a better level of care by having those nurses, because they become the person that the patient will feel comfortable calling. When my patients call our office, they don't ask for me, they ask for my nurse. And because they know they're going to get good advice, they know they're going to be helped, and the nurses take that initiative on to do that work, and that's job satisfaction for them. So consequently, we don't have a turnover of staff because they're all working at the top of their license, doing things that they think are important. And so I think that is a key to having that medical home and the team-based model of care, which we don't invest enough in that in the United States. And I think that needs to be reversed as we enter the value-based care arena.
These are all fantastic points. And we're going to get into, like I described it as we led this off, we're going to get into some very specific tactics, and we'll look at individual lower cost of care settings and what can be done to optimize ambulatory surgery centers, what can be done to make them work better within a health system that's still trying to fill and push volume through its ORs. So we're gonna spend some future topics looking at real discrete strategies and tactics. But I had an interesting question that came to me from one of my current clients at PYA, and the question was, and I'm going to ask each of you to answer this in just a minute, but if you, being me, and now you, had $1 million to invest today, and you had the expectation for some sort of a return, not necessarily a margin producing return in your environment, but for some sort of a return, where would you put that $1 million, and what would be your expectations for it? So we'll shake up the order, and I think Dan will let you go take a swing at that first.
I would invest in a custom resource management tool. I think you keep and you lose patients and their families based on how well you as a practice and a clinic communicate with them. You know, if you have easy mechanisms, multimodal mechanisms to communicate with patients and their families, And this is not just pediatrics, right? I have elderly parents. I'm going through trying to communicate with their healthcare provider, especially as a physician, because I love my family, but they're not clinical. So really trying to get to the heart of, okay, what's going on with them? How can I help relay this message? If you have ways for people, it's easy to communicate with the teams, and as Jim mentioned, it's not default to the physician. Is there a team of frontline MAs, frontline nurses, team of APPs? How is there a tiered response to get to the right appropriate person who's most successful to answer the question you need? Scheduling. I have no idea why people cannot schedule things online for every clinic practice everywhere. And the amount of barriers we put to do that, to see specialists, how do we create mechanisms where when it's clinically appropriate, there's decision support with your parent support to refer to that, getting access to your labs, being able to share that information. The more that, or also like release of information. Why do we have days where you have to physically go, pick up a piece of paper, come back, have someone sign it, fax it, or send it? Why is there not online portals across the board? Like all of this should be able to be done remotely. So if you are running a practice where you're still requiring people to physically fax things, stop.
Yeah.
I mean, so it's really, practices are going to succeed and fail on how easy they make it for their patients and their families to engage with them and interact and be partners with them. You make it easy, you will have people knocking down your door and you'll have more patients than you know what to do with.
Yes. It's
And the business model will work however you set it up. If you have more patients you know what to do with, it makes it very easy to make it a financially solvent situation.
Mhm. Yes. So put the focus back on enhancing consumerism.
It's focus on the front end, because it is, the downside, and I say this as a physician, is that we don't, traditionally with Jim as a very notable exception, we don't think beyond, there's a patient in front of me, I need to take care of them, this is what they need, this is the best practices, evidence-based. We don't really think holistically how we deliver care, but also our clinic at large delivers care and how we interface. I mean, most of us are just kind of thinking patient to patient, moving on and not really taking a step back at the whole science of how we deliver care.
Yes, well said. Scott, somebody gave you $1 million. What are you gonna do with it?
Put it on black and hope to get 2. No, I actually like Dan's answer better than mine. I think as I was thinking about this, I would invest in virtual behavioral health, and the reason I say that is that I just know we've piloted this, we've moved it in some of our primary care offices, et cetera. And first of all, the relief the doctor has that they have backup when they're dealing with an issue they're not trained at. And I think it's a major overriding issue that has gone unaddressed in this country. And there's no way we're going to be able to have enough bricks and mortar and psychologists to help take care of all this. And I really think this model is the model to really assist not only our providers, but our patients in helping them get better. So I would spend $1 million on virtual behavioral health.
Wow, insightful. Okay, Jim, a lot of good things have already been talked about. Your turn.
Mine's a little bit of takeoff on Dan's. I hate to admit it, but I would invest in more effective triaging and scheduling, because by the time the patient gets to my office, sometimes they're already mad because it's taken so much trouble to get an appointment and get in. And we with good triaging scheduling system, I think we can accommodate more patients. We can divert patients from seeking care in the wrong spot, and create better quality and better patient satisfaction.
Well said.
And actually less havoc in an office setting.
Mm-hmm.
Access wins every time. Like patients don't care how smart you are, how smart you think you are, or You know, your outcomes, if you offer the best access, people will follow the path of least resistance and they'll come to you. They presume, you know, that, you know, we all deliver evidence-based high quality care. You know, you're right. There's a small subset who are very, very intentional, but the vast majority of the population at large will go where they can get care the quickest.
For sure.
And I agree with you, Dan, and most studies have shown that patients equate access to quality. They're one and the same.
Right.
Yeah. In their mind, it's their equivalent. Yep, that's what, well said. So thinking back on all the things that we've talked about, is there anything from this discussion that you would like our audience to really be thinking about, to get the wheels turning on? And I like your behavioral health been there, Scott. That's something that I see across the country, regardless of client. That is a problem everywhere. But what from your current world, what today is your biggest bugaboo that you want to put more thought into? So I know this kind of came out of the blue, but I was thinking about it as you guys were all talking. What is it that keeps you guys up at night?
I can start if you, or you want to go ahead, Jim?
No, go ahead.
Okay.
I'm happy to go second.
I think it's really, for your practice, being very intentional about what's in scope and out of scope, and saying, this is what we're going to provide, but if you're not going to provide, be very intentional about it. And then with that lens, do basically a community needs assessment. What is the community we serve? What do they need? What's the data telling us? You know, if you're a multi-specialty practice, you know, you need to look at, okay, what's your median lag time? What's your third next available? You look at it, and I mean, let the data drive your decision, but be very upfront, not only internally, but with your community, saying this is what we are offering to the community, but also saying this is what we're not offering, but you know, we have partners in the community and we want to refer you. And so it's really just being upfront, but then also focusing, letting the data drive to say, okay, is this a productivity issue where we need to help our providers develop kind of tier teams like Jim talked about to be more productive and practice top of license to improve access? Or do we need to hire more people? And how do we get intentional in terms of recruiting and retaining and hiring more people to meet that needs? But having that focus, I think, really sets a clear path forward, because unfortunately many times in healthcare we're very opinion-rich, data poor. Everyone has opinions on something, but we really need to get to, okay, what is the data? What does success look like? How do we define that? How we articulate it? And then how do we move from X to Y by Z?
Well said. Jim, you were chomping at the bit a little bit.
I would say the thing that keeps me up and that I'm constantly trying to figure out a way to make it better is, how do we make it easier for our patients? These are all things we talked about this last half hour, but we constantly seem to be making it harder, and there are more barriers for our patients to get the care where they need it, when they want it. And I think we need to make an investment in that philosophy of how we're going to make it easier for the patients to navigate the system.
Well said, too. Okay, Scott, what's keeping you up?
A little bit of a different perspective than sitting in the chair I sit in. I for years and years and years, we viewed our local hospitals as our competitors, and you know, what are we going to do? How are we going to get more inpatient market share? And as value-based care, depending on where you live, how quickly it has taken root, is I see all the new entrants into the market, and you know, nobody's building pneumonia hospitals anywhere because it doesn't make money. Everybody is looking at what really makes the money, and it's surgery, and it's urgent cares, and a whole lot of other different things. And I believe we continue to think about fee for service and how we're going to make money. And in the meantime, I think a lot of different type of competitors are taking the cream off the top, and we've got to figure out and not be afraid to make mistakes and how we're truly going to compete in a different environment. And I think if done anything successfully in our careers, we've tried some things. Some of it's worked, some of it hasn't. But you almost have to have the mentality of an entrepreneur. And my business is under attack, and what am I going to try to do to make it better? And I think if you can bring that mindset, and I think that's where ultimately how we're going to succeed in terms of trying to figure out how we're going to compete in a rapidly changing environment.
Yeah, that's again well said. That's something I think as we go through this series, there's so many subtopics that we could talk about through all of these. I mean, just sitting here talking about access. What are the strategies to improve access? Dan threw out things like let data drive the decisions. Well, what are some good dashboards? What's a good dashboard look like? What are we using to manage our practices? And how are we defining what matters most? And how are we getting to where we know that what we're doing is improving the lives of our patients? So we've got a lot of topics that we're going to take a deeper dive into. As for our audience, I want to thank them for joining us, because this is was kind of a novel idea. This is intended to be a kickoff to a webinar series on optimizing ambulatory care. We hope you're finding the content informative and applicable to all the myriad solutions that the healthcare leaders that will be tuning in to listen to this and to watch us talk face on a daily basis. If there are tactics that are keeping you up at night, please submit them to us. We'd love to have an expanded roundtable discussion where we've got other people who are exploring ideas. So we hope this has been value add. We really look forward to doing this again and taking individual slices and delving into some of the strategies and tactics necessary to improve certain environments. And it'll be fun. I think we can all learn from each other. That's the one thing I think I've learned from the 2 years in consulting is you don't have all the answers, and you have to pull some answers from people who are dealing with the problem up close. So thank you. Jim, Dan, Scott, couldn't thank you more. We'll keep this going, and we'll look to see the audience again soon. Thank you, everybody. More to come.
Thank you so much to today's presenters. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any questions you may have. You will soon receive an email with the contact information of the presenters and a recording of the webinar. Also, the slides and recordings for every PYA webinar are available on the Insights page of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about our full range of services. On behalf of PYA, thank you for joining us and have a great rest of your day.